Understanding that suicide is preventable, communities across the country are implementing strategies to address and prevent this serious public health issue. I'm Alicia Samji from Prevention Institute, and I'm interviewing Mego Lien from Santa Clara County to learn about her suicide prevention work, including how her and her team have adapted strategies during the COVID-19 pandemic and tips she has for other locales. Mego is the Prevention Services Division Manager in the Behavioral Health Services Department in Santa Clara. Thanks for joining me, Mego.
Thanks for inviting me, Alicia.
So several communities have turned to the Centers for Disease Control and Prevention's Suicide Prevention Technical Package, both for guidance on promising practices and further strategy development. How have you used the CDC's technical package locally?
Well, I think one thing that the suicide prevention field and public health fields really agree on is that suicide and as a result, suicide prevention are really complex issues. And so to address any really complex issue, you really have to work in collaboration with a lot of different sectors and partners, and you have to do a wide range of interventions. So when you're coming into this issue, it can feel really overwhelming to know where to start. And then when you're in the thick of implementing these strategies, it can really easily, you can really easily get kind of lost and forget about the direction that you're taking. And so I found that the CDC technical package was helpful for both of these things. And I find it to be a really essential program planning tool for a couple of reasons. The first one is that the technical package is rooted in evidence. And so when we're implementing it, we know that we're investing time and resources into things that have some evidence around it that they work. And so we know with some kind of confidence that we're going to be progressing towards our goal of reducing and preventing suicides. The package has, I think, 7 recommended strategies, and our program in the county right now is actively working towards at least one of the approaches in 6 of those 7 strategies. And then secondly, the technical package applies fundamental public health models that I've been using my whole career, like the prevention continuum, the socio-ecological model. And so I know when I'm looking at it, that if I implement it, I'm going to be taking action comprehensively on this issue. So it's really kind of a concise reminder as you're implementing programs about the range of strategies that are required. And I like to kind of check back in with it every now and then to get ideas for what else we can be doing in our program.
I hear from a lot of folks working in different communities that they'll take the technical package and learn from the best available research and then, really adapt it to their community and the context that they're in. Mm-hmm. And that's been so important during COVID-19, and the context has totally changed. And I'd like to know, what's an example of how you've adapted your strategies in the context of COVID-19?
I think our ability to adapt in response to COVID-19 has been really rooted in what we already had in place before the pandemic hit. And so a good example that I can think of in our program is our public awareness campaigns and our efforts around communicating to the public around risk factors and protective factors for suicide.
And what did you have in place prior to the pandemic when it comes to public awareness campaigns?
So a lot of different things, I would say. It starts with the data. So before the pandemic, we already had an established partnership with our medical examiner coroner's office that allowed us to look at the number and the rates of suicide deaths in our county on an annual basis. So, it's a bit on a lag, so we don't have 2020 data available right now, but in 2019, we were already seeing higher suicide rates in our county that was causing us some concern. And we were doing analysis by culture, like age group and race and ethnicity. So we were able to identify that, for example, white, Caucasian, middle-aged men were a priority when it came to the data and the burden of suicide in our county. So the data was one thing that we had in place. And then we already had campaign materials because we had been running campaigns for a number of years. And so we had things that we could go and kind of retest with focus groups with middle-aged men to see what would really resonate with them right now. And then the last thing is our cultural competency efforts. So our county is really diverse culturally, and we had already made a commitment that every public awareness campaign would focus on at least 2 cultural communities, and they would incorporate these concepts of culturally competent suicide prevention that we'd identified working in partnership with one of our university partners. So one of the examples of this are warning signs for suicide that might be more common in some cultural groups versus others. So in different campaigns, we would make sure to highlight those particular warning signs.
So with all of that in place, how did you adapt that in the COVID context?
Yeah, so everything was already in place. So it didn't actually require us to make too many adjustments for COVID-19. We already had political will and backing for these kinds of campaigns. And the request actually came from our Board of Supervisors to run a COVID-19 specific suicide prevention campaign because they were looking at that 2019 data and sharing our concern about the increased rates. We knew from the Public Health Department that the Latinx Hispanic population was really heavily burdened and affected by COVID-19. And so we kind of did an overlap of the data that we had and decided to focus our campaign on English speaking and Spanish speaking middle-aged men. And then in terms of the campaign materials, we made some tweaks that addressed kind of the overlapping shared factors for COVID-19 and its impacts on mental health and for suicide. So isolation is one of those shared factors, feelings of loss, feelings of stress, anxiety, and depression, things like that. So in the end, you'll see, the campaign materials just had slight modifications. You'll see a tagline that says COVID-19 affects us all. Help is available. Call the Suicide and Crisis Hotline. So that's an example of how we kind of merged the messaging to address both issues. And then the last thing was has to do with placing the ads in the media. We really thought about where people were getting their information from during COVID-19 and shelter in place. So we placed ads on the radio, especially sports radio and classic rock stations because of the middle-aged men target audience. We went on Spotify. We went on some websites online that we thought these audiences were likely to visit, and then some YouTube ads also. And then we did something kind of new for us, which is called geotargeting or geofencing, where you can place your ads on people's mobile phones when they go within a certain radius of a location. So we geofenced locations people were going to during COVID, like all of the COVID testing centers in the county, pharmacies. There were a couple unemployment offices that were still open during shelter in place, and grocery stores. People have to still get their food. So we geofenced those too.
Sounds like you're really strategic about your media buys and really smart about thinking about those overlapping factors between COVID-19 and suicide. I've seen some research that talks about how suicide prevention mass media campaigns appear most effective when they're paired with other strategies. So can you share a little bit more about what else has been coming up in your work during COVID-19 and some other areas of focus?
Definitely. So, as I said before, it has to be a comprehensive response that does a lot of different things. And so we always run our campaigns at the same time as the other strategies that we have going on. So one example is our school-based suicide prevention partnership, which is in its 3rd year, I believe now. We work with school districts on suicide crisis response protocols, on training everyone in the school community in mental health and suicide prevention, and on social emotional learning. And all of our trainings were already online, and we were able during COVID to move our technical support consultations virtually too. We were seeing from the schools that We had more schools reach out during distance learning to train their teachers, and there was a focus on adjusting their crisis response protocols to be able to accommodate distance learning and identifying students virtually if they were struggling and how do you get them to services that they need, et cetera. And the schools were also showing more of a focus and emphasis on social emotional learning, which is an area we're starting to delve into, but definitely I saw the effect of the pandemic increasing people's attention around SEL, mostly because there's so much stress and uncertainty from the pandemic faced by the students, but also by the school staff. And so I think there was more of a desire to make those connections as best you can through virtual classrooms, through the curriculum, and really infusing social emotional learning into the school and learning experience.
In what you're saying, I'm really thinking about the CDC's technical package again, and some of those strategies like teaching coping and problem solving skills, and can really see how your work matches a lot of those kinds of recommendations. So what kinds of tips and recommendations do you have around adapting strategies during catastrophic events for others who might be in similar positions as you, working at the local level on suicide prevention?
Yeah, when I look back and kind of reflect, I realized that our ability to respond to any crisis really depends on the planning that you did and the preparedness that you had way before the crisis ever took place. And so, in our county, we already had a strong infrastructure for suicide prevention. Our suicide prevention strategic plan was passed about 10 years ago, involving a whole bunch of community stakeholders and then all the way up to our board of supervisors. So that political will was there. It was written down on paper. We had the work group set up, the staffing, the funding, all in place for years before the pandemic. With our school-based partnership too, that's in its third year, I said, and those relationships, with the districts and the school staff, the trust, and the ability to just pick up the phone and talk to a wellness coordinator at a district, for example, that was really built up from over a matter of years before the pandemic. And then we had worked pretty extensively to make sure we got those online trainings funded and in place and disseminated across school districts. And it had already started to build a reputation where school staff were saying, I do like this training and would recommend it to other people. So that was all in place. And then also, as I mentioned before, the infrastructure and the resources, the agencies for the public communications, all of that was also already in place, that data-based approach for creating campaigns. These are just some examples of things that I think were really essential in helping us adapt once the pandemic hit. And then I touched on this a little bit earlier, but I thought it was useful to really recognize the overlaps between the issue and the impacts of COVID. And so we were already in the business of preventing crises before they occurred or before they got worse. And so in a lot of ways, responding to COVID was about making slight adjustments and really just intensifying everything that we were already doing. And so we saw things like the isolation, the sense of loss, anxiety, and the loss of social connection. These were things that were getting worse because of COVID, and things that would also contribute to suicidality. And so kind of recognizing that and realizing the areas where we needed to intensify our approach was helpful in responding to the pandemic.
Thanks, Mego. I'm really glad you spoke to kind of the political will pieces and the partnerships and using the evidence and, public health frameworks, and how really putting all of those things together is really what has supported success in your work. Thank you for joining us today.
Thank you.